problem with the connection. Are you with me? Okay, so we were discussing inflammatory bowel disease. Basically, there are two diseases which are common in inflammatory bowel disease. So it is a relapsing and remission enteritis involving the involving the lower GI tract, small intestine, and maybe part of the large intestine. Okay, so Crohn disease is a basically a extend into the deeper. So it is a transmural inflammatory disease that involves from the epithelium, subepithelial area, and leading to the transmural. While ulcerative colitis is a disease which has a inflammation and ulceration only the epidermal area and the apura muscularis mucosa. It doesn't. It is not transmural. It does not extend from the endothelium to the whole intestinal area. So it is a superficial disease. Ulcerative colitis, like Crohn disease, is transmural. So transmural inflammation, Crohn disease, it has a skip lesion, while ulcerative colitis is usually ulcers which are continuous. If you have a proctitis or colitis, it will be a continuous inflammatory process involving the whole part of the area. While Crohn disease is in the form of small areas of granulomas and inflammation and involving gut, and then there is a part of normal gut, then there is another part of inflamed gut. So these are skip lesions which are healthy part of lesion with the area of alternating inflammation. In Crohn disease, ileocecal area is the most commonly involved in 50% of cases, and the colonic area may be involved up to ileocolic and colic area in up to 20%. So it is a descending disease, while ulcerative colitis is a ascending disease from starting from the proctitis, meaning your rectum, your sigmoid, and the maybe involving the whole of the colon, that is pancolitis. So again, number one, Crohn disease is a transmural disease. It is involving the whole thickness of the intestinal wall. Ulcerative colitis is a superficial ulceration up to the muscularis mucosa, while Crohn disease extends from mouth to anus. Ulcerative colitis ascends from rectum to the ileocecal up to large gut. Crohn disease is a transmural inflammation with skip lesions, means you have involved area of the gut inflamed and then you have a healthy area. These are called skip lesions. And you can have regional, that is called regional enteritis, or you can have ulcerative colitis, that may be pancolitis. And we usually see the ulcerative colitis. This is the normal anatomical area which is involved in Crohn disease. You can see it can have ulceration in the mouth, aphthous ulceration, may involve the esophagus, stomach part of small intestine, and the maybe part of large intestine. If you look at the ileocecal region, this is the most common area which is involved in Crohn disease. And in reverse to Crohn disease, ulcerative colitis is a disease which usually involves rectum first. So it is a ascending inflammatory disease of the colon involving rectum, which is called proctitis. Then you can have a sigmoiditis. Then you can have left-sided colitis, or maybe transverse and the descending colon may cause pancolitis. So these are the two other forms of inflammatory bowel disease. Apart from Crohn's ulcerative colitis, you can have collagenous colitis, lymphocytic colitis, ischemic colitis when you have a mesenteric infarct. Some patient with atrial fibrillation or some intramural thrombus can have a embolic event and can lead to ischemic colitis. Dasher disease, infective colitis, maybe because of Salmonella, Shigella, other E. coli, and Enterobacter and other bacteria. Even you can have pseudomembranous colitis after use of antibiotics. And You can have other form of colitis, but we will focus on two diseases, that is Crohn's and ulcerative colitis. If we look at the epidemiology, Crohn's disease, age of onset is around elderly group, and ulcerative colitis is more common between teen and 30 years of age. So it is a young age disease which usually presents diarrhea, abdominal pain, sometimes bleeding. We'll discuss the symptomatology. So ulcerative colitis incidence is about 2 to 14 per 100,000, and younger in ulcerative settings, elderly group usually ethnicity, both diseases are common in Jewish population. And in our part of the world, male absorption syndrome is more common, but still we have inflammatory bowel diseases. Female, male predominance almost equal, but Crohn's disease slightly more in female as compared to male. Smoking, yes, smoking, although is a risk factor for ischemic heart disease and all, is a well-known risk factor. But for GI, peptic ulceration risk factor. But for ulcerative colitis, there are few studies which say smoking doesn't is not a factor for causative agent as ulcerative colitis. But Crohn's, yes, people who smoke, they have a high risk of getting Crohn's disease rather than ulcerative colitis. Oral contraceptives, yes, Crohn's disease has some hormonal etiology, and history of appendectomy, protective or not very, Crohn's disease is usually not associated, but ulcerative colitis, there are few articles which say if you have a appendectomy done, it is a protective for your for you having ulcerative colitis. Monozygotic twins and dizygotic twins had a tendency, but more in Crohn's disease as compared to ulcerative colitis. Etiology, no exact cause is known, but there are different factors which are involved in having these inflammatory bowel disease, like genetic factor, immunological factor, microbial. You have different sorts of infections, and some psychosocial factor. We'll discuss that dietary habits are very important for intestinal diseases, especially having ulcerative colitis and Crohn's disease. Genetic factor, as we discussed, ulcerative colitis is more common in DR2 related genes, more common in females. While, the Crohn's disease is more common in female. Crohn's disease is more common in DR5, DQ1 alleles. So ulcerative colitis DR2 and Crohn's in DR5. And it is a 3 to 20 times higher incidence first degree relative. So if you are monozygotic twins, has a high incidence of having a disease like 6% in ulcerative colitis and 58% in Crohn's disease. Dizygotic twins, usually they don't have any precipitating factor, but 4% in dizygotic twins. So immunological factor, as we know, it is a disease of unknown multifactorial causes, and one of these immunological factors, the of the gastrointestinal tract. So it is defective suppression, immune system is activated, and it has organ stimulate the other inflammatory cells like macrophages, B cells, and recruit more inflammatory cells by stimulation of the leukocyte and vascular. So leukotriene, interleukins, this all cascade of inflammatory process starts, and you have a immunological factor. Probably some triggers they take place and lead to immune activation and destruction of your endothelium. Your intestine is either it is a Crohn's or ulcerative colitis. Now, this is the pathogenesis of inflammatory bowel disease. Usually, it is a slide, but for understanding the immune activation, this is the if you look at the at here, genetic predisposition, but in Crohn disease, the immune these cells are, and they lead to the ulcerative colitis is a disease of the large gut, which a colon is involved. This is the, you can see the anatomical area of distribution of part of the large gut. You can see the colitis, you can see the proctosigmoiditis, you can see the left-sided colitis, and you can see the pancolitis. So this is a regional involvement of the distribution of ulcerative colitis. So it is a disease, either rectum, your sigmoid, your left-sided colon, or a whole of the colon. While in Crohn's disease, you will see the skip lane, one healthy area, one disease area, another healthy area. So Crohn's disease is a skip lesion disease, and this is a continuous disease. Okay, so ulcerative colitis may be mild, moderate, and severe disease depending on the sigmoidoscopic appearance of the colonial mucosa or on the symptomatology. That is the 5 things, especially if you have the frequency of stools. Number 2, if you have a bleeding PR, if you have a fever with low hemoglobin, and other that we'll discuss later on. So mild disease, there is some redness, erythema, and congestion. Per appearance, fine granularity you can see in mild disease of the ulcerative colitis. While in moderate disease, there is erythema, coarse granularity, and there may be contact. If you put a stigmatoscope or colonoscope, you can have a contact bleeding, but there are no ulceration as such in moderate disease. In severe disease, you can when you pass an endoscope, you will see the blood oozing through the congested erythematous and mucosa, and there are some ulcerations, means you can see the ulcers in the large gut. Long-standing disease, chronic disease can lead to pseudopolyp formation, mucosal atrophy, and can lead to precancerous condition. That is, you can see that disorientation and leads to some precancerous changes. And eventually, it can lead to shortening and narrowing of the colon. The colon becomes, after inflammation, there is fibrosed and there is a narrowing of the colon. And sometimes acute infective phase is so severe, it can lead to toxic colitis, toxic megacolon, or dilatation of the large gut in high risk of perforation. So toxic dilatation or toxic colitis is one of the severe complications that can lead to perforation and peritonitis, the patient go into shock. So this is the macroscopic. If you look at the endoscopic picture, there you can see the small ulcers there, and there are the pseudopolyps formation, which lead in a chronic phase of ulcerative colitis. So if we look at the microscopic picture, the characteristic feature of ulcerative colitis with a small crypts, atrophy, and irregularity, superficial erosions, mixed inflammation, and there is crypt abscesses. So small crypt, if you look at the normal mucosa, and you can see the goblet cells, and then you can see the atrophy and absence of goblet cells, and then you will see that in late stage, there are crypt abscesses. This is the late complicated form of ulcerative colitis. And this is the picture of pseudopolyp formation with ulcers. This is another picture of ulcerative colitis, and you can see the ulcers are up to the muscularis mucosa. They are not transmural as compared to the Crohn's disease. This is a diffuse inflammatory with the crypt abscesses and crypt distortion, the histopathological picture. Okay, so in Crohn's disease, macroscopically can affect any part of the GI tract, starting from after ulceration to, so it is a disease from mouth to anus. So it is a as I told you, the inflammation is throughout the gut wall. It can be, that's the reason they can lead to fistula formation and perforation. Segmental with skip lesion. As I told you, this is in Crohn's disease. You can have a healthy part of the intestine and the involved disease part. These are skip lesions. And another picture is cobblestone appearance and creeping fat adherence and fistula. Fistula formation because of the transmural inflammation of the disease leading to fistula formation. This is the again endoscopy picture of in Crohn's disease. You can see the ulcer and creeping fat and some inflammatory focus. So in Crohn's disease, you will see the granuloma. There is a small granulomas. This is the picture of Crohn disease where ileocecal valve is involved, and you can see the part of ileocecal junction which is inflamed, and there is a narrowing of the ileocecal area, and you can see the ulcer here and cobblestone appearance. So upper the area is a normal intestine, which is a skip area. So skip area means healthy area, then is a disease area, the ileocecal junction that is involved in Crohn disease. Okay, microscope. If we look under the microscope after taking biopsy, there are abscesses you see in the mouth, focal crypt abscesses can be seen, granuloma, papillomatic, and submucosal and subserosal lymphoid aggregates, and it is a disease of transmural inflammation leading to. So this is a very characteristic picture of Crohn disease. This is, you can see the granuloma formation and abscess ulceration. Okay, now clinical manifestation. So we discussed the different etiological factor, immune activating triggers, and some macroscopic pictures and microscopic pictures. Now we see the how these patients present to our clinic or OPD or an emergency. So ulcerative colitis is usually disease of the large gut. It almost may present with proctitis, or patient may have diarrhea, rectal bleeding, tenesmus, and passage of mucus and crampy abdominal pain. Urgency, proctitis usually cause urgency and severe pain. Patient has a tenesmus, very bad tenesmus and urgency in case of proctitis. Otherwise, they will have diarrhea leading to mucus per rectum and bloody diarrhea. Diarrhea and bleeding per rectum, intermittent, may be mild, and patient may ignore it. But once the patient have proctitis, they pass the fresh or blood-stained mucus form stools, and they will have tenesmus, urgency, and feeling of incomplete evacuation. So proctitis will usually present. Patient will say, I have very bad pain and tenesmus after before defecation, and I have to rush for washroom to pass my stool, urgency, and feeling of incomplete evacuation because of inflammatory process and the inflamed gut. With the proctosigmoiditis, you can have even constipation with diarrhea. Severe disease can lead to liquid stool mixed with blood, sometimes pus and fecal matter. This is a bad disease when you have a severe inflamed colon with loose diarrhea and bloody stool, and can lead to toxic dilatation and perforation. Okay, physically, patient with ulcerative colitis may have proctitis. If it is a disease localized to the rectum, your proctitis is there, you will have localized tenderness and anal canal. If you do the PR, you will see the patient is having very bad pain, and if you see the finger after PR, patient may have may have a blood stained finger. That means there is a local inflammation and bleeding. So extensive disease, usually tenderness on pelvis of the colon. You can see the pelvis, especially the left flank tenderness in case of descending colon, or there may be a epigastric or the right flank tenderness in case of tan colitis. If you have a toxic dilatation, you can have distended abdomen with the element of peritonism, guarding if there is a perforation. Toxic colitis, severe pain and bleeding, and if perforation, you can elicit the signs of peritonitis, that is muscle guarding. You will have a patient may be febrile, toxic with muscle guarding, and you can ball sound may be absent. So this is the severity of ulcerative colitis. What is the grade of severity? Is it mild disease, moderate disease, severe disease, or fulminating colitis? So it is the bowel frequency, number one. Number two is the temperature, stool in blood. Number three, temperature. Number four, pulse. Tachycardia is another sign of toxicity and disease severity. Hemoglobin, patient bleeding may have low hemoglobin. ESR and CRP raised is another sign of acute inflammatory process. That means it is a bad prognostic marker. So if you are passing patient is passing less than 4 stools, it is a mild disease. Up to 4 to 6 is a moderate, and more than 6 are the severe disease, bowel frequency, and fulminating colitis maybe more than 10. Blood in stool, intermittent, usually sticky, but it may be frequent and continuous in case of fulminating colitis. Temperature, patient is usually normal, it is not that toxic, but in severe disease, patient will be toxic, he will be febrile, and will have abdominal tenderness and muscle guarding, depending the pancolitis or perforation or some other complication has taken place. Patient will be tachycardic in case of severe and fulminating colitis, while hemoglobin will be low because of the bleeding. In mild disease, you will have less than 4 stool, but there is a intermittent blood, but patient not that toxic, pulse is okay, he's not anemic, and ESR is less than 30. But in moderate and severe disease, you have patient is toxic, he is tachycardic, he is anemic, he is having ESR more than 30, and even CRP more than 35. So these are the bad prognostic markers. And abdominal tenderness and abdominal distension with tenderness is in fulminating or toxic megacolon. So these are the grades of severity of ulcerative colitis, and you can see the clinical manifestation. You can start from the inflammatory bowel disease, abscess ulceration. You can patient look for anemia, uveitis, fever, sweating. Again, picture of septicemia, shock state. Patient may be jaundice, that is association with primary sclerosing cholangitis, or because of the toxic hepatic process. Abdominal pain, arthralgia. Patient with inflammatory bowel disease may have arthropathies like large joint inflammation, even sacroiliitis, or even ankylosing spondylitis. Weight loss, yes, is again bad prognostic sign, and you can have sacroiliitis, primary sclerosing cholangitis. You can have iritis, you can have episcleritis, or they may be other eye complication. Skin rash, there are two classical in Crohn's disease, erythema nodosum. In ulcerative colitis, you can have pyoderma gangrenosum. And diarrhea and blood and mucus, you can see according to the severity of the disease. This is the whole systemic and local and systemic manifestation of both inflammatory bowel disease. Okay, so you had the patient, he had been having abdominal pain, diarrhea, sometimes bleeding, his ESR is raised, he is mildly anemic. So this is a moderate disease. And how would you make your diagnosis? Okay, we'll see laboratory test, we'll go for endoscopy and biopsy and radiological investigation. And biopsy is very, very important to see the ulcerative colitis or Crohn's disease, depending on the thickness of inflammation, whether it's a transmural in Crohn's disease and it is only up to the muscularis mucosa in ulcerative colitis. So laboratory tests will ask for CBC to look for hemoglobin, CRP level will be raised, ESR will be raised, platelet count may be increased because of excessive bleeding, because there is reactive thrombocytosis because of bleeding, and hemoglobin is low because of GI loss, and fecal calprotectin levels. These are the new tests which can be seen in feces, and they are indicator of relapse and relapse of the disease, and these are the markers for acute inflammation and relapse. If we go for barium enema, you can see the normal gut look like a very good large gut with a hostile pattern. But in the ulcerative colitis with the disease, you can see the fine mucosal granularity with the superficial ulcers, collar button. These are the, you can see in the area of large gut with the collar button, pipes, stem appearance, loss of hostration, and you can go to the narrowing and ribbon counter, or there is a short colon that is in advanced stage of, or there may be a toxic megacolon. In case of toxic megacolon, you don't go for barium studies, but it is a endoscopic picture. Sigmoidoscopy always abnormal. You have to go for either you go for sigmoidoscope or fiber optic colonoscope to see the macroscopic picture of the gut colon, and at the same time you can take the biopsy. As we already we discussed the endoscopy picture, there may be an area of granularity, hyperemia, and then you can have superficial, even touch bleeding leading to ulcers formation and spontaneous bleeding. So these are different grades of endoscopic severity of colitis. So loss of vascular pattern, granularity, friability, and ulceration. So these are the severity of inflammatory colitis. Healthy colon, and you can see the red hyperemic and ulcerated colon. This is again in ulcerative colitis. You can see the proctitis leading to even if you have a toxic megacolon leading to perforation, bleeding. These are the complications leading to cancer formation and stricture formation. So these are the complications of ulcerative colitis. You can have localized stricture formation, toxic dilatation leading to perforation, bleeding, and cancerous transformation. This is another picture of ulcerative colitis with the clinical manifestation, like you can have toxic megacolon, you can have carcinoma transformation, pseudopolyp formation, hemorrhoids, and mucosa ulceration leading to bleeding or rectum. You can uveitis, iritis, or episcleritis, and you can have pyoderma gangrenosum, erythema nodosum, arthritis, especially. This is a picture of rheumatoid arthritis. It's not like in enteropathic arthritis, you get large joint involvement. This is a wrong picture. Usually it is a sacroiliitis, or even you can go for ankylosing spondylitis. In chronic ulcerative colitis, you can go for even amyloidosis because of the chronic inflammatory process. By sclerotic cholangitis, primarily sclerotic cholangitis in liver with cholestatic phase, jaundice, and high alkaline phosphatase. Extraintestinal manifestation, you can see the whole picture of eye involving episcleritis, uveitis, bone formation, and you can have urinary tract infection. In skin, you can have erythema nodosum, pyoderma gangrenosum, aphthous ulceration, stomatitis in the mouth, and liver. You can have hepatic fatty liver disease, steatosis, biliary tract obstruction may be part of gallstones or sclerosing cholangitis. Joint, especially large joints, are involved leading to spondylitis, sacroiliitis, peripheral arthritis, large joint, or ankylosing spondylitis or sacroiliitis. Circulation, you can have phlebitis, and these are the systemic manifestations: mouth, skin, joints, your liver, kidney, eyes, and local abdominal complication. As we discussed, it may lead to stricture formation, toxic dilatation, cancer transformation, or massive bleeding and perforation. Okay, Crohn's patient usually present with, we discussed the ulcerative now, Crohn's disease, abdominal pain, diarrhea, weight loss, low-grade fever, jejunal-ileitis disease, usually localized to the right iliac fossa, and there is a localized tenderness, and maybe because of the localized inflammation and malabsorption. Okay, chronic Crohn's disease can lead to destruction of the small intestine, more absorptive part of the intestine, leading to malabsorption. The patient may present weight loss, anemia, steatorrhea, and failure to gain weight. Colitis and perianal diseases, this is another element of Crohn's disease, where you can have mouth to anus involvement. Patient may have bloody diarrhea, may have passage of mucus, lethargy, malaise, anorexia, and weight loss. And how would you make a diagnosis of Crohn's disease? Again, we'll see the endoscopy picture, radiographic, biopsy, and CT enterography if that is available. So again, you will see in CV, you can have low hemoglobin if there is anemia, raise ESR, raise CRP, is the acute phase protein reflecting the extent of inflammatory process. And leukocytosis if there is separate infection, or hypoalbuminemia because of the malabsorption syndrome. Then in anemia in Crohn's disease, you will see the inflamed gut, and you will, this is a string sign. This is Another important is a rose thorn ulcer, because this is a transmural disease. It will see small ulcers. These are called rose thorn ulcers, and area of disease involved, and they are skip lesions on barium enema. Colonoscopy, if your gut, large gut is involved, you can have colonoscopy, rectum areas, you can have areas of granuloma and ulceration. This is again endoscopy picture of Crohn's disease with the involvement of the large gut, and you can see the granuloma formation, ulceration, and the part of fibrosed, infected, inflamed area. CT enterography, you can see mural hyperenhancement. Your transmural disease in Crohn's disease can be a enhanced transmural area with stratification, engorged recta, and peri-enteric inflammatory changes. So this is the specialized CT enterography. Okay, so intestinal complication in Crohn's disease can be a part of fistula formation, abscess formation, cancerous transformation, or sometimes small gut perforation and strictures. And what is our objective? Patient has presented to you with abdominal symptoms. Now you have examined the patient. You have make your mind it is inflammatory bowel disease. Either patient have multi-systemic involvement with abscess ulceration, or you have to make a difference between Crohn's and ulcerative colitis by endoscopic and microscopic biopsy picture. Plan of management: improve your symptomatology. So first goal is to improve the patient symptoms. Then the drugs are used to have a remission of the disease. Maybe you have an active disease and try to suppress the disease and get a remission. And then remission is by different modalities you achieve, especially if you are using corticosteroids and glucocorticoids. They are time. Once patient is improved, he is gone to remission, his ESR is settled down, CRP is okay, bowel frequency has settled down, abdominal pain has settled down, all parameters are settling. Now this is the time, if he was put on steroid, you can taper off the steroids. And now the maintenance of remission. Your patient had disease that in remission, now have to maintain it, and don't let the disease process again into start again, relapse again. So relapse and remission are very important. Once you achieve the improvement, symptomatic remission is there, you have used steroid, you have taper off it, and now you contain the tissue healing and cure. Cure is very few patients, they are cured, but usually you achieve the remission and patient symptoms are improved, and don't let your patient to have a complication like stricture formation, toxic dilatation, even perforation or toxic megacolon, even cancerous transformation. So objective is to treat as soon as possible. Don't let your patient go into complication of the ulcerative colitis. The treatment of is a whole. You have to lifestyle changes, your dietary habit, your medication, and surgical options. So we'll as we discussed, Crohn's disease can be tested by smoking. To stop smoking if someone is smoking, reduce your stress and regular exercise, and take rest and good healthy diet. Drugs which are used in both inflammatory bowel disease, especially in ulcerative colitis, 5-aminosalicylates. These are the anti-inflammatory agents which are used, especially if sulfasalazine, mesalazine, or salazine. These are the drugs which are anti-inflammatory. And immune modulating drugs like steroids and immunosuppressants. These are the drugs which suppress the immune activated destruction of the intestinal mucosa. So if you suppress your immune system, and that is the T cells are activated and you have an inflammatory cascade of interleukin and all that process. If you suppress your inflammation is over, you will achieve the remission. Antibiotics, if suppressed infection is there, you can use metronidazole or rifaximin or ciprofloxacin. And biological therapy, the new agents which are anti-nuclear factor or biximab, we'll discuss it just a little bit. 5-aminosalicylates, I told you, 5-salicylic acid, sulfasalazine, isalazine, oxalazine. These are the drugs which are anti-inflammatory. They are good in inducing remission and maintaining remission. And topical application of these drugs, especially if you have localized proctitis, you can use the suppositories. That is, the suppositories are just pushed into the rectum 15 to 20 centimeter beyond the anal verge, and they stay there, and the inflammatory process gradually improved because of the local application. Then you can have another option, that is a retention enema, liquid retention enemas. Either they are steroid, 100 ml, 100 milligram hydrocortisone and 100 ml normal saline. They are steroid retention enemas. They are pushed to the anal verge, and your steroid, they are locally effective. They improve the local inflammation. Oral, we already discussed. You can use the oral drugs, which are 5-aminosalicylates and even systemic steroids. So either use oral or systemic steroids or anti-inflammatory drugs. Local application in the form of suppositories, or you use retention liquid enemas. In mild to moderate ulcerative colitis and Crohn's disease, usually remission is achieved and may reduce the risk of colorectal cancer. Adverse effects: these salicylates may have nausea, headache, epigastric pain, sometimes little bit diarrhea, hypersensitivity, or these are minor reaction. One should monitor once you start the medications. And renal function should be monitored in patients who are on 5-aminosalicylic drugs, and pregnancy and breastfeeding is contraindicated. Steroids, okay. Role of steroids, I told you, whether they are in the form of enemas, suppositories, or systemic steroids. They are anti-inflammatory agents to moderate to severe relapse of the disease. So what they do is they have anti-inflammatory effect. They inhibit the process of inflammation. And budesonide can be used, prednisolone can be used 40 to 60 milligram, they give 1 mg per kilogram body weight in divided dosage. And this is the systemic steroid. As I told you, once you achieve the remission, you try to maintain and taper off the steroids over course of 2 weeks. Antibiotics, sometimes if there is a superadded infection, you have an inflammatory process top of infection, then you can use the metronidazole, you can use ciprofloxacin or rifaximin. Immunosuppressant, we already discussed, it is an inflammatory process. Some immune system has triggered to some agent, whether it is autoimmune or some other process. So immune modulating drug, especially azathioprine and methotrexate, they are usually used. Azathioprine and methotrexate. So 6-mercaptopurine, thiopurine, and cyclosporine can be used. Cyclosporine, again, they are the drugs which can be used as immune modulating drugs. These are the drugs which are called steroid sparing. Patients who require high dose of steroid, like more than 20 milligrams per day. And these are drugs which are introduced to taper off the steroid, because long-standing steroid, as you know, can lead to Cushing syndrome, can lead to secondary diabetes, hypertension, and all these complications can be prevented if you add steroid-sparing drugs, and these patients can be switched to steroid-sparing and taper off the steroids. Biological marker therapy like infliximab are used now, anti-tumor necrosis factor monoclonal antibody. These are the new line drugs which are used under specialist care. They are not that oftenly used, and given under specialist observation. So after medication, we have to make patient is malnourished, and you have to give him good nutrition, iron supplements, pain relief as acetaminophen, and sometimes you can use very mild laxatives and anti-diarrheas like loperamide if they are having loose stools. Okay, now surgical option. What are the indications for surgery? Number one, Disease which is not controlled by medication, like fulminating disease, toxic megacolon. You have a patient in a shock state. You try to improve by steroid, by local retention enemas, by all your medication. And if patient is not improving, he is a patient for surgical intervention. Chronic disease with anemia, frequent stool, urgency, and tenesmus in case of proctitis. Steroid dependent in life. Steroids are not being tapered off, patient can relapse again. So you think of surgical intervention. Risk of neoplastic, if you see the local neoplastic change, always refer after endoscopy. So these are the patients who are usually once or 2 year endoscopy is done to see their colonic mucosa. If there is some change, and then you can take the biopsy and refer as early as possible. Extra-intestinal manifestation, if they are so severe, and severe hemorrhage or stenosis that takes place, patient has going to subacute or acute intestinal obstruction, then you have no option to to relieve that obstruction and go for surgical intervention. Reconstructive procedures are different done. Maybe you will see in surgical wards and in your surgical lectures, but these are proctocolectomies done, and sometimes ilioanal pouch is because you are your normal defecation is preserved by doing the ilioanal pouch. And other procedures are proctocolectomy with ileostomy and rectal anal dissection. These are the procedures you can do. But basically, once you have a Crohn's disease or ulcerative colitis, you try to diagnose your patient and put them on early 5-monosalicylates, and if required, steroids. Remission is achieved, and try to taper off the steroids and maintain your remission. And good nutrition, dietary habits, and lifestyle modification. This is another picture of strictureplasty. That is once you have a stricture formation, especially in Crohn's disease. This is a very bad patient present with nausea, vomiting, abdominal distension, and intestinal obstruction. You can do the strictureplasty. Thank you very much. I hope basically in the university question you will have inflammatory bowel disease, especially Crohn's or ulcerative colitis. So please try to read your topic, and wish you all the best. Allah Hafiz.